Kia ora, and thank you for the incredible opportunity to present to you today. My name is Jane Kinsey, and I'm a Senior Research Affiliate with the Centre for Healthier Children and Families at UCLA. I have this opportunity as I'm the Aotearoa New Zealand Harkness Fellow, sponsored by the Commonwealth Fund, and my mentors are Dr. Neil Halfon, Adam Schickendans, and Dr. Shirley Russ. This fellowship enables people from many countries across the world to come to the US and learn and to exchange research, policy and practice ideas, and to impact on systems, to improve outcomes, and to achieve health equity. My presentation today is about how adverse childhood experiences, or ACEs, demonstrate the importance of understanding inequity through the lens of trauma and adversity. Despite being known for its incredible beauty, outdoors and academic and sporting achievements, there are some very sobering statistics regarding child health wellbeing in New Zealand. Some of the statistics are listed there, and they are heavily weighted towards demonstrating the inequity that exists between white European population and Māori, our Indigenous population in New Zealand. One of the points that I'll be expanding on more in this presentation is the data analysis from the 2019 New Zealand Family Violence Survey, where they showed that about 30% of Māori have 4 or more ACEs. As described by UNICEF here, it is urgent, and it is with this urgency that I came to my fellowship to find out more tools, more information on how we can make systems change to achieve health equity. We need to go back briefly before we can move forward. So we really should be spending some time here on understanding where ACEs came from. And they really came from the seminal ACE study in 1998, which was a partnership between Kaiser Permanente and the Centre for Diseases Control. The study used 7 categories of adversity to demonstrate the link between adversity and leading causes of adult death. 3 categories are in child abuse, psychological, physical and sexual abuse, and 4 categories were exposure to household dysfunction in childhood, which included substance abuse, mental illness and violent treatment of mother or stepmother, as well as criminal behaviour. The survey did show the link, and they also demonstrated that there was a dose relationship where people who had higher ACEs tend to have a higher chance of early death or poorer outcomes from diseases such as heart disease, suicide, respiratory conditions. The 1998 study showed that about half of the participants had 1 or more ACE and 6.2% had 4 or more. And as mentioned prior, New Zealand conducted a survey and used that survey responses to effectively replicate what the US study did in terms of understanding the prevalence of adverse childhood experiences in the population. But what they found with that information was that more than half of the New Zealanders who participated in the survey had 1 or more ACE, and 12% experienced 4 or more. This slide compares the data of those 2 studies, and it does show that there are some differences, with the major one being where in the 4 or more ACEs category, where New Zealand is 12% compared to the US in 1998 as 6. When you break down the data a bit more in New Zealand by ethnicity, there's a stark difference. White European data shows a little more than half with 1 or more ACE and 10% with 4 or more, whereas for Māori, our Indigenous population, the data shows 3/4 of the population with at least 1 ACE and 27% with 4 or more. This further emphasises the inequity, and it's quite apparent, isn't it, when you break down the data. There are other well-documented and accepted adversities that were not included in the original ACE study, and the original study never intended that the adversities included in their study were the only ones or the strongest ones or the most impactful. So since then, there's been a growing literature of recognition of other adversities which have and can have strong impact on child wellbeing, and they're listed here. This diagram was used in the original ACE study, the pyramid on the left, and that's showing the link between adverse childhood experiences and potential early death. And the diagram on the right is beginning to build in some of those more wider systemic issues that were identified in that previous slide, such as social determinants of health, local contexts conditions and historical trauma from issues and experiences from events such as colonisation or forced migration or enslavement of whole entire populations. I propose that ACEs can be used as a proxy measure for health inequity. But to address ACEs, we must accept that we face a complexity challenge. There's a need to describe the complex causes and consequences of ACEs in a simple way so that we can raise awareness, communicate the issue in a way that guides and motivates and prioritises child health development research, policy and practice. When I first came to begin my fellowship and started getting access to all these amazing databases and information and talking to experts and incredible researchers in the field, I found it was a very broad topic. It covers many disciplines and refers to multiple frameworks and paradigms to explain both the cause, the onset, and the impact of ACEs. Therefore, I saw an opportunity to attempt to bring these together in one visual representation. My model, it attempts to explain the complexity, it attempts to illustrate the root causes of inequity and the root causes of adversity, starting to demonstrate the interacting factors of adverse childhood experiences as well as positive childhood experiences, to apply the public health prevention continuum in a way that's practical, and also to orient people to which part of the system an intervention is targeting and at what stage of the life course. This slide is the model that I've been referring to. I understand it's a lot to take in, and I trust that when we've had a chance to unpack the components of the model, it will be easier to understand. Just to help quickly to orient you to the model as we go forward through the slides in the next little while, the colour of the lighter green are elements that are potential positive childhood experiences. The one that are a bit darker in that sort of blue turquoise colour are the elements that are potential adverse childhood experiences. And the yellow boxes are more temporal factors that float across the diagram. So to begin to unpack the model is effectively based on a life course health development framework and incorporates aspects of 4 commonly used models for capturing the dynamics that lie between a child, their family, the community they live in, and the policy which surrounds the community, which can cause inequity and give rise to ACEs. So those models include the family stress model, Bronfenbrenner's bioecological model, the stress continuum, and relational health development systems. If we start with the original family stress model, this model suggests that economic hardships such as low or insecure employment or unemployment can place marked financial pressure on parents. Families may find themselves unable to provide basic necessities such as food, access to transport, often needed to reach places of employment and education, payment of household bills or insurance, and access to services such as healthcare. This pressure can cause parental emotional distress, even clinical depression and anxiety, which in turn can cause or contribute to family conflict, therefore impacts on a child outcome. While the original model focused on socioeconomic circumstances, it's important to know that there's other stresses that are more difficult to quantify but do influence a family unit. These stresses come from the more outer layers of our ACEs model and include community factors and policy factors. On a day-to-day basis, pressing issues for families such as inadequate housing, social isolation, lack of transport, poor access to quality healthcare, low quality food, and limited employment opportunity impact either directly or indirectly on a family's activity and their interactions. We know these factors do disproportionately affect people of colour, contributing to racial and ethnic inequity. And it is of note that many of the factors in the model are largely outside of the family's control, hence beyond their own sense of agency to change. These entrenched issues profoundly contribute to the existing health inequities as they influence individual biology, health, behaviour and choices. It takes a family to raise a child and it takes a community to raise a family. This quote was an adapted one from a well-known one, adapted by Dr. Ed Shaw, and I really think it's a useful quote. Wider issues such as climate change and community context represent threats that are starting to impact on nations and communities and of course families who are doing their best to raise children in the best possible way that they can. Past and present political influences and decisions contribute to societal realities, such as experienced racism or marginalisation or stigma and discrimination, and historical trauma from colonisation and other such policy, all of which impact on people's day-to-day lives today. The bioecological model begins to start bringing those layers together. And it recognises the interaction and the interdependencies of the micro, the meso, and the macro, and the global factors and their impact on families. All of these levels interact with each other within and across levels, and all contribute to how stressors are experienced by individuals and as they form families at a micro level. The intergenerational nature of ACEs is critical to appreciate. Impacts cause alterations in gene expression, which can be passed to future generations. The study of epigenetics has helped us to understand how trauma can pass to children decades later. So when we think about historical policies and practices, such as colonisation, such as enslavement, such as, stolen generation and institutional care for children who are being taken away from their families, that trauma can be passed through people generation after generation after generation. The Harvard Center on the Developing Child developed a model which described a continuum of stress, from positive to tolerable and then to toxic stress. We think that this is a useful way to conceptualize different types of adversity and stress and how our bodies and brains respond. While positive stress and tolerable stress responses are normal and an essential part of healthy development, like getting ready for a running race, preparation for an exam, a toxic stress response can occur when a child faces strong, frequent and or prolonged adversity, such as physical or emotional abuse or household dysfunction, without having adequate adult support. This conceptual model of ACEs places toxic stress centrally to visually demonstrate its potential to have a pivotal influence on child health development trajectories. The Life Course Health Development Framework highlights the integration of the bioecological models across time. The ecological contexts change over time as a child develops, and these multiple layers should be considered at different stages of development. The ecological context of an unborn, for example, is much more focused on the proximal family relationships as well as the context of the family home, compared to an adolescent whose ecological contexts are potentially much wider, where they are involved in a variety of extracurricular activities, interacting with a variety of different people, and spaces as well. It's important to understand that the impact of ACEs on any child depends not only on the number and the type of ACEs themselves, but also on the quality of the child's relational environment. At an individual level, ACEs are not a destiny, and instead are one component of a complex web of risk and protective factors that surround every child. While single-factor ACEs can absolutely have a large impact on an individual, the full impact of each ACE can only be understood within the context of these multiple interacting factors in a complex dynamic ecosystem. Different patterns of ACEs and buffers interact with each other, affected by the degree, the nature, and their timing, which therefore then determines the dose received effectively of toxic stress that developing child may experience. This brings us to consider relational health development. This figure is the depiction of the multiple relationships and interactions that a person can have throughout childhood. This model incorporates the element of time as it relates to the child's stage of development. The Life Course Health Development recognises the prenatal and the perinatal periods as critical and sensitive times, as well as adolescence, as they are all aligned with where a lot of the modification is happening in the brain's development. This means they're sensitive to both positive but also vulnerable to the impacts of adversity. As a child grows, schools and peer relationships play an increasing role in shaping a child's development, providing new opportunities always to address the impact of ACEs. The Life Course Health Development Framework also highlights that different impacts of ACEs that different ACEs can have different impact depending on the developmental stage at which they're experienced. For example, Witnessing a family violence can have a negative impact at any age. However, for infants and young children, this may be particularly harmful as they lack the processing ability of older children to filter the circumstances, the degree, and likely outcome of the interactions. Similarly, a mother's postnatal depression can affect attachment with a newborn with profound impacts. Whereas if that occurred when a child was at middle school, it may have less of a marked effect. Peer bullying during adolescence, we know, can be substantial for them and impact on their development. Safe, stable and nurturing relationships are proposed as an effective mechanism that can turn off the body stress machinery in a timely way. While the health of the relationship between the child and their family caregiver is important, healthy relationships with both parents, siblings, extended family members, trusted friends can buffer a child even in the face of adversity. Relational health, therefore, represents vital pivot points in each child's developmental ecosystem. If we think back to the family stress model, this focuses on family functioning as it relates to parenting ability, which has a significant influence on the outcomes for the child. It's important to note that families can take many forms and can change over time and can look different across different communities and different cultures. Therefore, for the purposes of understanding the impact of ACEs and for developing meaningful interventions, each person and family should be asked how they themselves define these relationships. This model regards families as key, with the potential to buffer adversity when it occurs, with the potential to break intergenerational cycles of suffering. Family functioning therefore becomes an important pivot point that can drive a child's health development in an optimal or less optimal way. The way that a family functions results from a kind of seesaw between stressors and coping resources, each of which operates through multiple levels of the child's developmental ecosystem. The model emphasises the influence of the outer layers of the ecosystem to support family functioning and can prevent them from becoming overwhelmed by external stresses, which are largely policy-dependent realities and out of the remit of a family to feel that they can influence. If families have high coping resources with few stressors, then the child is likely to have more enhanced potential. Interventions at a family level that support or enable optimal family functioning, even in the face of adversity, are undoubtedly a component of the needed response to ACEs. Conversely, for families who experience high levels of stressors with low coping resources, carry risk that their children are more likely to have reduced potential with poorer outcomes in both health and social scenarios. The model illustrates that if children have experienced significant exposure, they are at risk of entering adulthood with heightened sensitivity, more significant stressors, less adaptive responses, and reduced coping abilities. It's important to capture the emerging adult health trajectory, as childhood is really preparation for adulthood. It is not just the number and type of ACEs that will determine these outcomes, but also the developmental stages in which they've experienced their relational ecosystem throughout life, as well as the pattern and experience and timing of the positive childhood experiences. It's important to remember that positive experiences and nurturing relationships can occur at any time and can continue to bend trajectories in more optimal directions throughout the life course. Therefore, although early life experiences are formative, they are far from deterministic, with opportunities for change and improvement throughout life. This entire model is underpinned by the public health prevention continuum from primary, secondary and tertiary prevention. The model aims to visualise potential leverage points that can become the targets of interventions designed to change or disrupt the developmental ecosystem from one that produces adversity to one that produces caring, positive relationships. Traditionally, prevention strategies have been conceptualised in a linear way, with escalation pathways as a problem takes hold. However, this model of ACEs suggested that public health continuum must be applied not linearly, but in a more complex and multi-level systems way, if it is to be effective, by working at all levels with cross-sector partners over multiple generations. The model illustrates that the whole developmental ecosystem is contributory to the child's future health. Many of these factors in the child's ecosystem are potentially modifiable if effort is invested at all levels of the public health continuum. So this is the model again, and I'm hoping it now makes a bit more sense to you. Primary prevention approaches, more on that left side of the diagram, lie substantially within that wider social, political and environmental drivers of health. Governments and institutions can take steps to acknowledge deep, pervasive and structural roles and factors that, such as colonisation and racism, that have played into shaping people's lived experiences, and the desperate need to develop policies and services that can address past and historic trauma while drawing on family and community strengths to contribute to the prevention of ACEs through address inequity. Examples in this primary prevention space include commitment to the adoption of trauma-informed policies across government, such as secure housing for young families, paid leave for parents, restorative justice approaches, new opportunities for multilingual students in schools, and economic security for households. More midstream or secondary prevention approaches, which is more in the sort of central part of the model, should include having a trauma-informed workforce in all human services who can demonstrate cultural responsiveness and address implicit and explicit biases, and are family and community focused, partnering with them to understand their context, identifying risks, and co-designing interventions with them. At a tertiary level, which is more on the right side of the diagram, it's important to invest in trauma-informed programs that can respond rapidly to support families most impacted by significant adversity. This requires services to work in genuine partnership with families and communities in a timely, culturally responsive, context-specific, integrated and strengths-based way, so that they can empower people and families to address their holistic needs. So my main message is ACEs are not simple. However, they are preventable. And we need to do this by enhancing the protective and buffering factors. How do we do that? We do that by understanding a child's context. We develop policies and systems that can enhance family health development, that we're family focused and we think cross generations, and we build a workforce that's strong in relational health, are trauma informed, are culturally responsive, and foster safe, secure, nurturing relationships. I've got some key takeaways, and I hope that this model helps to encourage prevention efforts to go early and invest upstream. I believe that achieving child health equity will make achieving health equity overall more likely. We need to embrace the complexity of ACEs in genuine partnership with community and our cross-sector colleagues. We need to support a joined-up approach so that everybody can see themselves in the picture and that we can work in a polycentric leadership fashion, which really means in good partnership. There are no easy solutions. Although the knowledge is growing, it is far from being a comprehensive evidence base. Our task is to learn forward together. Thank you for the opportunity to present this to you today, and I welcome any questions or comments or feedback on what I've spoken about. I hope you enjoy the rest of the conference. I look forward to talking soon. Ngā mihi nui. Kia ora.